Welcome everyone to today's talk. Today's Better Hearing webinar is about untreated hearing loss and cognitive decline. Today's presenters include myself. I'm Caitlin Whitson. I'm a faculty audiologist here at the UNC Hearing and Communication Center. I've worked here for about 2.5 years now as an audiologist, and I graduated from UNC's Doctor of Audiology program. So I've actually been here both as student and audiologist for the last 6.5 years now. I'm joined by Maria Roa, who is in her final year of her Doctor of Audiology program from the University of Pittsburgh, and she is with us for the entire year until she graduates next May. She will be co-presenting today with me. Some background on our clinic for those that are joining us from out of state or out of town. We're called the UNC Hearing and Communication Center, and we're a faculty practice of doctors of audiology within the School of Medicine of UNC. We're a nonprofit. We also serve as a training clinic for Doctor of Audiology graduate students. At our practice, we work with every hearing aid model and manufacturer. We run on an unbundled or fee-for-service business model, and we were one of the first in the country to pioneer this business practice for audiology clinics. We also offer balance or vestibular specialty testing, as well as tinnitus specialty testing. About a year ago, we opened a satellite clinic in Hillsborough, North Carolina. So now we have 2 locations. Our main clinic is off of I-40 on Farrington Road in Chapel Hill. And the other one is located inside the Orange County Sportsplex in Hillsborough. And for appointments, you can call that number on the screen for either location. Please subscribe to our YouTube channel. If you're watching this right now, it means you are on our YouTube channel. So please give this video a thumbs up if you like it and hit the subscribe button below. Our Facebook page is also listed there, facebook.com/UNCHCC. And we'll post links to all of our previous webinar videos there so you can stay up to date with everything that happens here. Today's talk is, of course, on untreated hearing loss and cognitive decline. And this is really a hot topic in the hearing world right now in the audiology community. And for today, we want to understand the concept of healthy aging, understand the relationship between hearing and cognition, and understand how to mitigate or reduce the risk of cognitive decline if we can. So let's start by talking about healthy aging. And what exactly does that mean? The World Health Organization defines healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. So that's a little bit of a mouthful, so let's break that down. And essentially it means it's a person's ability to meet their basic needs, learn, grow, and make decisions for themselves, be mobile, build and maintain social relationships, and being able to contribute to society. Healthy aging includes some different aspects that are important for being able to reach those goals. Those include avoiding injury, maintaining your physical mobility, being able to utilize health resources. Can you get to your medical appointments? Staying socially engaged, and keeping healthy cognition, remaining cognitively vital.
Today, we're going to look at how does hearing loss fit into the healthy aging process. Age-related hearing loss is also referred to as presbycusis. With presbycusis, we see that as we age, over time, very slowly, our ability to hear high-frequency sounds decreases. Oftentimes, we get these complaints in the clinic. I hear what's being said, but I can't really make it out. Everything sounds muffled. I have trouble hearing my wife, hearing my grandkids or children. These are very common complaints for this type of hearing loss. The type of damage that occurs in presbycusis is in the cochlea. And the cochlea is lined with little hair cells that are responsible for sending sound up to the brain for interpretation. These hair cells correspond to a particular pitch, and they're lined like a piano. In presbycusis, we see that these higher pitched areas get affected first. And so these hair cells end up dying, and when they do die, we get an incomplete picture sent up to our brain, and it's harder for us to interpret what's being said. And so in a perfectly normal cochlea, we see these hair cells working together to send up that complete picture. But when they're damaged, we start to have missing gaps in our ability to understand what people are saying. And that's exactly what happens over time as we age.
One thing we want to tease apart when we're thinking about hearing loss, and when I see patients in the clinic, this is always on my mind, thinking about what is a peripheral hearing loss or damage in the ear, the peripheral part of our auditory system, and what is a central hearing loss or damage in the brain itself that's making it difficult to process speech. The ears allow the brain to detect sounds around us. They send that message to the brain. But the brain is what's doing the processing of sound and giving sound meaning. Sometimes these things work in isolation, but often they are combined. So if your ear has lost some of these inner hair cells, then the brain, like Maria said, is not getting a clear picture, and it's working really hard to process. And when it's too difficult or too degraded of a sound signal, your brain just can't process it. And that's where we get the, what did you say? Or you just don't understand it all and you don't ask for repetition and the conversation moves on without you. So understanding these two concepts is really important and how they work together.
Now that we've covered a couple basics about hearing loss, we're going to switch gears and talk a little bit about dementia. Dementia is an umbrella term that's used to describe a range of symptoms associated with both cognitive impairment and changes in our brain structure. In these individuals, we might see a range of symptoms. Our intellect may start to be impaired. They might have difficulty solving problems that were once very doable. An individual might start experiencing memory loss, and it could start off with smaller things and eventually work its way up to not remembering who they are, where they are, or who they're surrounded by. Their ability to share their thoughts and ideas might also be impaired. And additionally, we could see behavioral changes. They might start being more agitated easily, or can start to experience delusions. As we age, we do have a certain amount of decline that happens in our brain, but with dementia, it's excessive, and this is not a normal part of aging. So who's at risk to get dementia? There are many factors that go into this, some which are not modifiable, and then many that are. So today we're going to look a little bit more on hearing loss as a factor. So as you could see, over the range of our adulthood, there are many factors that are at play for our development or risk to develop dementia. And you'll notice that hearing loss seems to be one of the most important ones. In fact, it's actually the #1 most modifiable risk factor from ages 45 to 65. So our next question would be, what is this link? How does hearing loss relate to cognitive decline? There are many hypotheses that try to explain this link, and today we'll cover some of the most prominent ones. We'll talk a little bit more about overdiagnosing dementia, the common cause hypothesis, cognitive resource depletion and cognitive load theory, sensory or auditory deprivation, And finally, social isolation and depression. Overdiagnosis. In the early stages of dementia, or early stages of our aging, dementia is something that we want to look for because that's not a modifiable risk factor. So it's very common for doctors and other healthcare practitioners to look for dementia. One of the most common ways that dementia is screened is with the mini mental state exam, or the MMSE. It is the most common assessment, and this is given verbally. So when a person has hearing loss, a lot of those instructions and vital information from that assessment can get lost. In fact, even only with a mild to moderate hearing loss, 16% of individuals may be misdiagnosed and flagged for dementia. So the real question is it miscommunication, or is there a real decline in cognition? The common cause hypothesis is the second link. We know what affects the ears also affects the brain. And a really good example of this is microvascular disease. So reduced blood flow to the ear, we know, is bad for our hearing. And likewise, reduced blood flow to the brain is bad for cognition. So it's not to say that hearing loss causes cognitive decline, but rather there's a common cause, microvascular disease, that's affecting both.
Cognitive resource depletion is another reason or theory behind the link between hearing loss and cognitive decline. But to understand cognitive resource depletion, we need to understand the concept of cognitive load theory. And this refers to the amount of information that our working memory can hold at any one time. And it was developed as a theory to help people who are learning a concept. What are the barriers to learning, and how can we make learning easier? And it's thought that the more difficult a task is, the more working memory resources are taken up. So your brain can only do so many things at one time. And if it's really busy doing this complex task, you're probably not going to hear someone walking up to you. If you're reading a book, it's difficult to walk and keep your balance. And so when we think about hearing with this graph shows this flow of information through the working memory. And it really illustrates the cognitive load theory in the sense that you have a stimulus coming in and you have your sensory memory of, oh, I'm hearing this sound. Maybe it's difficult to hear it and you have some interference, and then that leads to some memory loss. But let's say you get part of it and you recognize that there's a sound, you detect it, and now you're paying attention to someone who's talking to you. Now your working memory comes into play. Now, if it's difficult to process the sound, you get some more interference and you may forget part of what was said. But you'll also be thinking about, while you're listening to this speech, you're rehearsing, you're processing, you're really thinking hard about it. So if it's really hard to hear, you're working really hard at that. Now, if it's really easy to hear and you have, say, normal hearing, or maybe that person's voice, they're close, it's easy, then you're able to encode what they've said into your long-term memory. So it moves from one spot to the other. And then a week from now, you remember, oh yeah, they told me I need to go to the grocery store to get whatever. And you've remembered that. Now, over time, our long-term memory can decay, and then you get your last arrow going to memory loss. But essentially, this really illustrates that concept. And you want to think of your brain almost like it's got 4 little baskets in it. And the more complex a task, the more baskets are filled up. And if all of your baskets are filled up because you're working so hard to hear, it's really hard to remember what is said. It just doesn't get encoded into your long-term memory as well. And so this plays into our thoughts on cognitive resource capacity because there is a finite amount of resources for thinking and remembering and learning. And there are some declines seen in the efficiency of working memory as we age. And that creates a greater demand on our cognitive load. And so that means as we age, even without hearing loss, there are less resources for storing our thoughts into memory. But then having hearing loss on top of that leads to a constant load on our system. And the brain is working much harder to process a poor signal. It's really at the expense of our other resources for our working memory. And the brain working harder is not a good thing. People think, oh, I'm really using my brain, I'm working hard, but it's fatiguing, it's tiring. We don't want to make the brain work harder. Listening should be easy. There's been a lot of research looking into this, and when we look at fMRIs between normal hearing groups and even just mild to moderate hearing loss groups, we see reduced language-driven activity and increased compensatory activity in the prefrontal cortex. And what that's demonstrating is that even with a mild to moderate hearing loss, we see visually on MRIs an increased cognitive load on the brain.
Next, we're talking about auditory deprivation. So if we think back to that picture of healthy versus damaged hair cells, the damaged hair cells represent a lack of input that's happening in the auditory pathway, and the brain is not receiving that complete picture. So over time, when this lack of input remains, we can start to see atrophy in the cortex. Cerebral atrophy is when the loss of neurons or connections to the brain leads to a reduction in physical brain volume. And so this picture greatly illustrates this. And you could see that the normal brain is fuller and the damaged brain has gaping holes in it and is physically smaller. This process happens very slowly. And as I mentioned before, we do expect some atrophy to occur as we age, but that excess atrophy does lead to issues like dementia, seizures, or aphasias. And so when our brain is not receiving a complete picture of sound, what does that mean for these type of pathways? Research looking at MRIs of these individuals over time confirms that there are faster rates of atrophy for those regions that are important for language and memory. There's up to a 40% loss in brain volume for these areas. And what does that exactly mean functionally? Well, hearing loss is independently associated with a 30 to 40% rate of accelerated cognitive decline, more than normal. So even with just a mild hearing loss, you're at a twofold increased risk for dementia. A moderate puts you at a threefold increased risk for dementia, and a severe hearing loss will put you at a fivefold increased risk. Lastly, we're going to talk about social isolation. And with hearing loss, we see fatigue, difficulty in social environments, noisy places, restaurants, family gatherings. That is really difficult for a person to manage, and they're using so much of their resources and putting forth and understanding what they're hearing, that being socially engaged becomes a task, and they start to pull away and disengage. That loss of social engagement is known to increase individuals' risk for mortality and morbidity of diseases. And so when we look at this meta-analysis that was done in 2010, They gathered data on over 300,000 people. And when they compared individuals that had social relationships and individuals that had a loss of social engagement over a long period of time, 7.5 years, we see that those individuals with social relationships are actually at a 50% greater likelihood for survival, meaning that the risk of mortality goes down significantly. We also know that hearing loss and social isolation have ties to each other. Hearing loss, as we mentioned, is related to social isolation, and likewise, those individuals that are isolated could also very easily become depressed. Untreated hearing loss is therefore a modifiable risk factor for both of these things. And this is precisely what we want to avoid as we age, to keep ourselves healthy, engaged, and active.
And the cascade hypothesis really puts everything we've talked about into a single basket, because it's this combination of all of these things that can lead to some cognitive decline. So you have your social isolation, you have hearing loss, you're depressed, you're working really hard to listen, and you're using up all of your cognitive resources. And all of these things contribute. So far we've talked about these links between impaired cognition and hearing loss, including using our cognitive load, the brain structures and function, and social isolation. And I want to take a moment to talk about falls risk, because both impaired cognition and hearing loss can put a person at increased risk for a fall. 1 in 3 adults over the age of 65 fall down every year, and a fall for an older adult can mean life and death sometimes. It's really a huge risk, and something that we want to take care of and be aware of and pay attention to. And the risk of having a fall is higher for people with more severe hearing loss. And in fact, a risk for a fall increases 140% for every additional 10 decibels of hearing loss. And you can think that, that really makes sense, because when you have hearing loss, you have decreased environmental and spatial awareness. So if someone approaches you from one side and you don't hear them coming, and out of the corner of your eye, you see someone, it can startle you and you can fall down. You have difficulty localizing sound. You may not realize that a car is approaching, and you have fewer cognitive resources for gait and balance, keeping yourself upright. It's actually really difficult for people to stand and walk upright. But because we're so used to doing it, it's easy for young adults. But as we get older, it becomes more difficult as our muscles weaken, our inner ears weaken, and we're using a lot of cognitive resources for other things.
We also want to tack on healthcare utilization in this model that we're showing, because our ability to utilize healthcare when we have hearing loss and when our cognition is impaired is affected. And so when people have a poor ability to communicate, we see poor adherence to treatment recommendations when they do go and see their doctors. And this actually might lead to further accidental injuries or medical difficulties that could have otherwise been controlled for. People with hearing loss are also 3 times more likely to experience a preventable adverse event. And we know that hearing loss also puts people at higher odds for being hospitalized. And lastly, with hearing loss and communication difficulties, we also see a greater amount of dissatisfaction with overall quality, accessibility, and receipt of healthcare information. And so when we look at all of these different links between hearing loss and impaired cognition, we might start to make parallels with all of those different factors that go into healthy aging. And so if we put the two side by side, we might see that cognitive load surely is not good for our cognitive vitality. Changes in our brain structure, which are negative, and our function also are not good for our cognitive vitality. Being socially isolated also affects our ability to stay engaged as we get older. And fall risks and poor adherence to healthcare can affect our injuries, our ability to stay mobile, and utilize our resources appropriately as we get older. And so, needless to say that hearing loss not only affects cognition, but on a grander scale, is really not good for aging. We've covered quite a bit of information so far, but to sum it up, untreated hearing loss has several links to cognitive decline. And both untreated hearing loss and impaired cognition are related to healthy aging. And now our goal is, in the long run, we want to stay healthy. And by targeting hearing loss, we're really wanting to target communication, improving our communication with people that matter to us. It allows us to stay active and then our brain physically stimulated. We want to free up our cognitive resources and avoid cognitive fatigue, and overall help improve our compliance and outcomes with healthcare. So, where do I start? You could start by treating your hearing loss. The prevalence, or how common hearing loss is, doubles with every decade of our life. So there's a large amount of people out there that have hearing loss. By the time that we celebrate our 80th birthday, 80% of adults will have presbycusis. In this chart, however, you could see that treatment for hearing loss, like with hearing aids, is rather low and not doubling with every decade of life. It's actually about 20% of individuals that can benefit from hearing aids use them. So the big question is, can hearing aids reduce my risk of developing dementia? Well, we first want to point out that we have not said that hearing loss causes dementia, and that is not known just yet. But I do want to introduce a couple of research on this topic that'll give us a better understanding of what we can do, if anything, to mitigate our risk. The English longitudinal study of aging has been ongoing for a long time in the UK. And they're gathering data on older adults for many different facets. But in 2018, Ray and colleagues decided to just gather those individuals with hearing loss, and they broke them up into two groups. Those that were receiving treatment via hearing aids, and then those not treating their hearing loss at all. And they had a couple interesting findings. They found that non-hearing aid users were the ones associated with cognitive decline and hearing loss. And non-hearing aid users were also associated with higher odds of being socially isolated. But more importantly, those individuals with hearing loss that used hearing aids were associated with higher executive functioning. So when these individuals were doing memory assessments, they actually performed likewise to normal hearing individuals, which is very encouraging.
A study from France looked at a few thousand adults and measured their cognition with the MMSE over a 25-year span. They also found that hearing loss was associated with lower MMSE scores, so lower is worse on this exam. and that subjects with hearing loss who did not use hearing aids declined more rapidly on this exam. Subjects with hearing loss, but with hearing aids, showed similar rates of decline to normal hearing individuals. So that's implying that if some decline is going to happen, hearing aids are not going to stop it. It's still going to happen regardless of hearing status. But if you have hearing loss as a factor, perhaps hearing aids can prevent what would have occurred otherwise. Also, a UK study looked at hundred thousands of adults in their later adult years and looked at automated speech and noise testing as well as non-auditory cognitive tests. So you may remember the MMSE is an auditory test, so it relies on you being able to hear the questions. The results of the UK study is that poor hearing was associated with poor cognition, and that hearing aid use was associated with better cognition. So another point for treating hearing loss with hearing aids. Can hearing aids reduce the risk of dementia? Well, the answer to that is maybe. And we haven't had any randomized control trial studies published yet, but there is an ongoing study right now that's looking at answering just this question. And Frank Lin is a very famous researcher at this point in the hearing loss and cognitive decline realm, and he is heading a study for 3 years, and we'll have the results in 2022, looking at comparing cognition and quality of life between groups of people with hearing loss fit with hearing aids and who don't wear hearing aids. A word of caution about hearing aids, because if you were at any of my previous talks, you know that the way hearing aids are fit varies. And if you haven't watched my talk on hearing aid manufacturers, please watch that next, because it will help you understand these points as well. Hearing aids, you can't just buy one online and put it on and think, okay, I'm good to go. I'm going to reduce my risk of dementia, because that hearing aid may not be set appropriately for your hearing loss. The short story of it all is that the provider is greater than the product. And there are two different types of providers who are legally able to fit hearing aids, and those are audiologists or doctors of audiology and hearing aid dealers. And hearing aid dealers tend to work in retail settings and fit hearing aids, and they're certified, but they're not doctors. Hearing aids can be programmed different ways, and oftentimes people who fit hearing aids will just use a computer to estimate the output, and they don't actually measure it. And that measurement in your ear with a small microphone is really important, because how they're programmed really matters, and it matters more than the brand. So you should be wary of advertisements who promise to cure your hearing loss or promise to give you back normal hearing, because it just really doesn't happen. And you want to make sure that your provider is using best practice. Well, what is best practice? What does that mean? And there is a whole list of what best practice standards are for audiology, all the way from the time you first step foot in the sound booth with what tests should be done, all the way to the end of your hearing aid fitting process and assessing your outcome. One thing that is arguably the most important part of a hearing aid fitting is programming hearing aids with real ear measures. And I talk about this a lot, and I want to talk about it some more right now because it's so important for people to understand. Real ear measures is done by putting a small microphone tube down in the ear so you can measure the output of the hearing aid while it's in the ear in real time. And it's the only way to guarantee that the hearing aids are optimized for your hearing loss. because there's no one size fits all hearing aid. The size and shape of your ear canal, the size and shape of the earpiece of the hearing aid in your ear affects what sound reaches your eardrum. Computer software for hearing aids estimates the output based on the size of an average ear canal. I have never met a single person who I've put a hearing aid on their ear, measured it with this microphone tube, and had the computer software be accurate. Not a single time. Everyone can benefit from real ear measures. And so what can you do? Where do you go from here? If you're thinking about, all right, I might have some hearing loss, I want to get checked out, call an audiologist, have your hearing tested. Even if you don't really notice any difficulty, if you're over the age of 55, you should have a baseline done. And you should repeat the testing every 2 to 3 years. Be sure to see a doctor of audiology and not a salesperson. A doctor of audiology wants to help you communicate, and it's a whole person, a whole patient perspective. We're not trying to sell hearing aids. We're trying to improve communication. You want to treat your hearing loss sooner. We talked about cognitive resource depletion and sensory deprivation as being factors that negatively can affect cognition in the long run. And so you want to keep your brain pathways and your nerves stimulated with sound to avoid that and avoid loss of quality of life. And lastly, you want to treat hearing treatment like it's physical therapy. So it's not like glasses where you put them on and wow, everything's clear and great, I can move on and I never have to come back to my audiologist. That's not the case because it really takes time to relearn how to hear. When you're stimulating nerves in the brain that haven't been stimulated for sometimes many years, it takes time and you have to work your way up to it. And your audiologist is there to help support you during that process. So our takeaways for today are that hearing loss and cognition are very closely related, and that hearing well is important for healthy aging. Treating hearing loss may reduce the risk of cognitive decline. That research is forthcoming. And be sure that your hearing aids are optimized, clean, and up to date to get the most benefit from them. At our next talk, we will be discussing hearing aid cleaning and maintenance and how to make sure that your hearing aids are optimized. So if you're watching this before Wednesday, August the 4th, please join us. You can reach out to me directly to get the link to that live Zoom meeting. And Maria, if you'll go to the next slide, I'll have my email address on that contact information page. And if you're watching this after that date, then click over and watch our next talk on that. And we'll be talking about what you can do at home to keep yours or a family member's hearing aids clean and optimized, and what to expect from wearing hearing aids. So thank you for joining us today. We'll see you next time.